Yes, am I audible?
Yes. So, first session is yours, and I would like to invite you here and welcome you here. Dr. Rajat is Senior Consultant Medical Oncology at Fortis ISPL Noida, and he will be taking us through the consistently overall superior survival with Krixana. Over to you, Dr. Rajat.
Thank you. Good evening, everyone. I thank Dr. Manish, the organizers, for having me here. Thank you, Novartis. I am happy that I am 1 minute early than my scheduled time of 7:05. So I will start now. So we all know that ribociclib, which is with the brand name of Krixana, has changed the way we used to look at treating metastatic ER positive breast cancer. So, how has all this happened in the last 7 to 8 years is what we are going to talk about in the next 15 minutes or so. So, consistently superior overall survival has been seen with Krixana. Next slide, please. Yeah, so Krixana is indicated for the treatment of either postmenopausal or premenopausal women. With postmenopausal, its combination is with AI, that is in the initial therapy. With postmenopausal women in the second line, its combination is with fulvestrant. Although the trial for fulvestrant also included first-line patients, so FDA approval for first line in combination with fulvestrant is also there for Krixana. And in premenopausal women, which is the trial called Mona Lisa 7, the patients should have received along with AI and LHRH agonist therapy to make them postmenopausal. And in this trial also, there has been a superior benefit of adding Krixana with AI as compared to only AI. Next slide. So we will discuss what is the clinical evidence supporting the superior efficacy of Krixana, the review of literature which shows that there is an improved quality of life, and it will discuss what makes Krixana different from the other available CDK4/6 inhibitors in the market. Next slide. So in hormone receptor positive, HER2 negative advanced breast cancer, the first line patients have challenging journey, and what they expect from the treatment is living longer life, living well, that is the quality of life should be better, and living longer without chemotherapy. And all these three boxes, they are ticked very well with Krixana. Next slide. Next slide, please. Yeah, next slide, please. Can I have the next slide? Yeah, so Krixana has been studied in diverse patient populations, including a variety of patients in the first line setting. Next slide. So first of all, talking about the three trials that we are going to talk about: Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7. Importantly, Mona Lisa 2 and 3 are in the postmenopausal patients, whereas 7 is in the premenopausal patients, pre or perimenopausal. Also, very important to understand that Mona Lisa 2 and Mona Lisa 7 are first line trials, whereas Mona Lisa 3 was actually designed to be a second line study post aromatase inhibitor. That is why the Krixana partner was taken as fulvestrant, but there were about 50% patients in this trial which were first line as well. So that is why the Krixana plus fulvestrant Krixana is the only CDK4/6 inhibitor where it can be used in first line with fulvestrant. Next slide. So what is the difference in overall survival which has been reported with Krixana is what we are going to talk about. The longest overall reported survival is with Krixana only among all the CDK4/6 inhibitors that we have. Next slide, please. So achieving the longest reported median overall survival, we're talking about Mona Lisa 2 now. Next slide. So like I said, it is in the postmenopausal patients where the upfront patients of metastatic breast cancer, they were randomized ER positive HER2 negative patients. They were randomized to receive either Krixana plus AI or AI alone. Next slide, please. And then the the endpoints were PFS, which is the primary endpoint, and the secondary endpoint was overall survival. If you look at this being the secondary endpoint, which is the overall survival with Krixana in this population is 63 months approximately, vis-a-vis 51 months on with the control arm, which is only aromatase inhibitors. So certainly a huge delta, a delta of say about 12 months in overall survival is certainly something that we can vouch for, and with a p-value being highly significant and a hazard ratio of 0.76. So long overall survival has been reported with Krixana in this population. Next slide. Also important to know that overall survival, which is considered the gold standard in endpoint in most of the clinical trials, as all of us will agree, the OS benefit was not only there in the initial years, but in fact, as the years pass by and we have the latest update of this Mona Lisa 2, where this follow-up period has been 6 years, the quantum of benefit between the experimental and the controlled arm has continued to increase. It is about 12% in when we talk about the follow-up period being 6 years, whereas it is about 5.7% in the 4-year follow-up. So the control arm has not done increasingly well at all, but Krixana has continued to be there and has continued to work well in terms of overall survival. Next slide. So a sustained benefit has been seen, and what is more reassuring is that when we look at the subsequent treatment, so subsequent treatment, approximately 35% patients in this trial received a CDK4/6 inhibitor after progression in the control arm, but still the overall survival has been met, and consistently so over the years. So the difference in overall survival certainly is achieved if we are giving Krixana along with aromatase inhibitor in the first line in the post-menopausal setting, is what has been very firmly bolstered by the Mona Lisa 2 study and the updated analysis where the overall survival has been seen. Next slide. Time to chemotherapy also has been delayed by over 4 years. If you look at the TTC, which was one of the secondary endpoints of this study, the TTC of 50 months versus 38 months experimental versus control arm. So this also is something which is a very important point that one as a clinician has to highlight to the patient. So this also was certainly met in this study. Next slide. And the PFS of 25 months, although this PFS is nearly the same as compared to other CDK4/6 inhibitors, but certainly not a bad PFS at all. 25 months without chemotherapy in the first line, any day one would take that. Next slide. Time to response, very important. So many a times we do discuss that if the patient is having a visceral crisis and hormone receptor positive, then should we resort to chemotherapy? Probably with this graph in mind, there can be a little debate on that, because time to response is just 8 weeks, as we can see in this graph. 8 weeks is about 6 to 8 weeks is the period when chemotherapy also starts to take its effect. So not a bad time to tumor response at all. And in times to come, we may have the use of CDK4/6 inhibitors in visceral crisis patients as well, is something that we still would need to see, although visceral crisis patients were not included in this study. Next slide. Yeah, rapid reduction in tumor size, we've seen that. Next slide, please. So Krixana, consistent superior overall survival. Now we are talking about the other 2 trials, which is Mona Lisa 3 and then Mona Lisa 7. Next slide, please. So it is the only CDK4/6 inhibitors which has received a ESMO BS score of 5. That is, it ticks the 5 boxes of the treatment, the patient estimated OS gain, efficacy score, and the improved quality of life. Next slide, please. So talking about Mona Lisa 3, next slide, was a trial where postmenopausal patients in the second line setting post AI were randomized to receive Krixana plus fulvestrant or fulvestrant alone. Like I said in the beginning, that about 40% patients in this trial were first line therapy as well. Next slide. And what was seen was that the PFS in this trial was also superior to the control arm in the experimental arm, and the PFS in the first line was to the tune of about 30 months, and in the second line it was to the tune of about 12 months. And both of them taken together, the PFS was about 12 months, and all this PFS was superior to what was seen in the control arm. If you look at the overall survival in the intention to treat also was superior. It was 53 months versus 41 months. Again, very reassuring to see the OS also being improved in the favor of Krixana. Next slide. In the long-term follow-up also in the first line, if we see, the OS has not been reached, whereas the OS for the control arm is about 50 months. Next slide. Even for liver metastasis patients, the OS was 36 months versus 24 months. So liver metastasis patients, one of the bad subgroup of patients, also was benefiting with a risk reduction in death of about 37%. So it can certainly be used in patients who have got visceral metastasis or liver metastasis. About 40% of the patients in this study were having visceral metastasis. Next slide. And the time to chemotherapy here also was delayed by 4 years, which is again a good thing for our patients. Next slide. So the quality of life definitely is preserved. The pain scores are reduced as early as 8 weeks, and there is delayed deterioration in the functioning scores. So like I said in the beginning, that it ticks all the boxes that we want for our patients. Next slide. Reduction in tumor size as early as 8 weeks, similar to what was seen in the Mona Lisa 2 study. Next slide. And the survival benefit, like every clinician would want to know that what is the subgroup analysis. In the forest plot, we see that in the subgroup analysis, patients who are having metastatic sites less than 3 or more than 3, if they are having a bone lesion, yes or no, or involvement of viscera or no, all of the subgroups, pre-planned subgroups, they benefited with the use of Krixana plus fulvestrant compared to only fulvestrant. Next slide, please. And now talking about Mona Lisa 7 in the premenopausal patients. Mona Lisa 7 is the first line study of Krixana plus AI versus AI. Next slide, please. With the primary endpoint being PFS and the secondary endpoint being overall survival. Next slide. So we see that these patients, also premenopausal patients by convention, are not supposed to do as well as postmenopausal in advanced breast cancer, but these patients also benefited a lot with the OS of nearly 60 months is something which is a whopping number. All of us will agree with that. And the delta of about 10 months, that is a difference in OS that it could make in premenopausal patients, is also something worth appreciating. Nearly a 5-year median OS has been achieved in Mona Lisa 7. Next slide. Superior overall survival in patients with liver metastasis as well. So like I was saying, in Mona Lisa 3 also it was there, and Mona Lisa 7 also was no different. So we can be rest assured that even if the patient is having visceral mets, she is in safe hands if she is receiving ribociclib. Next slide. And same is the case with time to chemotherapy delay, which was the case with the previous 2 studies. Next slide, please. And the quality of life also is improved in favor of the experimental arm versus the control arm. Next slide. And reduction in tumor size as early as 8 weeks is seen, similar to what is seen in the first 2 trials. Next slide. Benefit of OS was seen across all the subgroups, whether the patient had a visceral metastasis or not, whether the metastatic, to know that is the time to prior chemotherapy and the starting of this Krixana plus AI, or if it was more
I think we have the Rajat signal are not there. Somebody can call Rajat.
Yes, sir.
Hello, yes. Am I audible?
Yes, Dr. Rajat, yes.
Yeah, sorry, there was a connection error. So I think next slide, please. I think we have come to the I have discussed almost all the points. So in the end, I would like to say that all the three clinical trials taken together, and with the overall survival which has been seen in all the three trials, it is quite reassuring as a clinician that if we are offering Krixana in the appropriate lines to our patients along with the appropriate partner drug, our patients are going to achieve a good quality of life along with a good survival. So this is my submission, and with this I thank Novartis, I thank Dr. Manish and the organizers for having me here. Back to the organizers. Thank you.
Thank you, Dr. Rajat. It was indeed a very crisp presentation, and we all know the overall survival is consistent with Krixana, and I think it is the best overall survival that we are seeing with the CD4/6 inhibitors. So the floor is open for discussion. If we have any questions from Dr. Rajat, we can ask.
I also think that Dr. Manish, I also think that with Krixana there is less of financial burden also. So when we are talking about only the scientific evidence, we may not talk about financial burden, but in the clinics we have to talk about those issues as well. So I've seen that that part also plays a lot of importance in the patient's mind, and this also is one of the factors in favor of Krixana. Of course, there is no doubt that the scientific evidence is hugely in favor of Krixana, but the other real world thing also we should be discussing, and this is what I feel in my practice. What are your views on it?
Definitely, I think India is a price sensitive market, and you definitely need to have a drug which shows survival benefit along with the cheaper to the pockets of the patients. So, Dr. Rajat, I have a scientific question. So, what do you feel? How do your patients do who are in visceral crisis with this drug? So, are you using this drug in visceral crisis? Because there is some evidence to suggest that few of the patients in visceral crisis, they also respond well to the Krixana, number one. And number two, what about the CNS penetration of the drug? So, I think Novartis has come up with a retrospective data in which they suggest that the drug crosses the CNS blood-brain barrier, and almost it is equivalent to abemaciclib, although we don't have a prospective data associated with it.
Yeah, so two parts to your question. First question is that if I have a patient who is having a visceral crisis and the performance status is absolutely good, then I would not, as of now, would like to use a CDK4/6 inhibitor. I would like to go with chemotherapy. Although I do understand that there has been a rapid time to tumor response, but still, for the want of further data, and because most of these trials have excluded the visceral crisis patients, I would still like to go with chemo. But having said that, you also, I think, will agree that most of the patients in visceral crisis will have a poor performance status. So if the patient is having a poor performance status, then I have no inhibitions in using a CDK4/6 inhibitor, because those patients will certainly not be good candidates for chemotherapy. And by giving CDK4/6 inhibitors, I am pretty sure that we will not be doing disservice to our patients. That is the answer to part number one. Part number two is about the CNS penetration. So I am aware of this retrospective data that you're talking about, but still, because we don't have a randomized study, I may be able to use Krixana in patients who have asymptomatic brain mets with close monitoring. But if the patient is having symptomatic brain mets, or the site of brain mets is at sites which are the critical sites, then I would like to use radiation followed by Krixana.
Very rightly said. I think we have the next